Okay, in a windy room to talk about, with Mel and Kim, to talk about this last little pearl that we have that we use in patients with inflammatory bowel disease. Primarily, I think, Mel, for ulcerative colitis at the moment.
It's only used in ulcerative colitis.
Okay, and it's called Tofacitinib. Yes. Kim's going to give me 2 lines now on Tofacitinib.
Tofacitinib is a JAK2 inhibitor.
Yeah.
It's a much smaller molecule, so this one we can actually give as a tablet form, so unlike the others.
So it'll escape the clutches of our digestive enzymes.
That's right.
Yeah.
We can absorb it quickly before it gets ravaged.
Yes.
Okay, and it works very well for ulcerative colitis, and the coolest thing about it is it's in tablet form. Mel, what are you going to say to a patient like me who's about to embark on taking Tofacitinib?
Okay, so Tofacitinib is our newest one so far, and it's given as a tablet twice a day. It's always twice a day. We start off at a dose of 10 milligrams twice a day. That's your loading dose. We would plan to keep you on that for 8 weeks.
Right.
A lot of people notice an improvement in their symptoms within the first 2 weeks. At about 6 weeks into treatment, we'll be speaking to you to see how you've responded to the medication. If you've had no response at all, we'd probably hear from you before, but at that point we'll be saying this is not going to work, we'll stop the drug. If you get a bit of response but you're just not quite there, so your disease hasn't really gone to sleep or you've not gone into remission as we call it,
right,
then we will give you a prolonged course of induction. So we would give you another 8 weeks after that. By the end of that 16 weeks, we certainly want to see an improvement and the disease to be in remission. We would then, if everything's gone well and your disease has gone nice and quiet, we'd actually go down to the maintenance dose, which is 5 milligrams twice daily. So you are always taking a tablet twice a day. If you are on another medication such as infliximab, such as azathioprine or mercaptopurine, we have to stop that treatment before you start this one.
Right.
Because they're both immunosuppressants and...
So you don't want somebody to be on too much
immunosuppressants. No, that's right. So we would stop it for at least 2 weeks before you start this treatment. Okay, because the azathioprine then will start to become lower levels.
Are there any particular, complications? Is it a drug that has, particular things we have to look out for?
Well, at the moment, this drug being new, we have to rely on a lot of evidence from other places and other specialties that they use this drug. There is some warning signs that we've been told that there is a slightly increased risk of clotting with this, such as pulmonary emboli, so PEs, or deep vein thromboses, DVTs.
Okay.
Now, to put it into context, actually active ulcerative colitis does also increase this risk. So we will be questioning you when you're in the nurse's clinic to find out about if there's any history of clots with you or your immediate family, for instance, your parents. And we might then actually say that perhaps we shouldn't use this medication. But if this medication is, you're going on to this medication after being on other ones that haven't worked maybe, we can still use this medication, but we might have to speak to the haematologists and have their advice while we use it.
So it will be brought up in discussions?
It will be, yes, and we will. It's part of the screening that we screen for this as well.
Yeah.
The other risk that actually they talk about, which to be fair, I think is a risk with all of the biologic group of medicines, all these targeted immune treatments, is it can reactivate certain viruses such as the varicella viruses, the one that drives cold sores, which is herpes simplex, and the one that brings out shingles, is varicella zoster virus. So we will be checking you when we go onto this group of drugs. We always check you for your immunity to these two viruses anyway. And if, like any other thing, if you are unwell when you're due to have your doses of these, we'd say just don't take the tablet. So that is the same. But obviously if you've got a virus or shingles or something like that, you'd actually stop taking it and you'd ring us up. Okay. The other thing we do is we will be checking your blood tests at 8 weeks.
Okay, so there is some blood testing.
There is some blood tests, but after that, 8 weeks after starting, which is the end of the first treatment phase, if you like, we check your lipids because your cholesterol might increase. We will have checked your cholesterol before you start the medication anyway, but if it increases a lot, then we might be asking your GP to give you some anti-cholesterol drugs.
Okay.
But this is a very small rise, and actually you have to remember that actually cholesterol rises when inflammation settles down as well. So we have to take that into account.
Okay.
Otherwise, you would be having blood tests every 3 months or so, and again, seeing the consultant at the end of a year to make a decision as to whether you're going to continue or whether you're going to have a break of treatment. The advantage this drug has, because it's a small molecule and you have it as a tablet, is you seem to build up less antibodies to it, so you can actually increase to treat a flare-up if you get one later down the line, so you can go back onto the treatment dose, 10 milligrams twice daily. And there is some thoughts that actually, if you come off the drug for what we call a holiday from the drug, then you can actually restart it without any risk of having a reaction because you've made antibodies to the drug.
You've made antibodies?
Yeah,
okay.
You won't make antibodies to this drug because it's a small molecule drug.
Okay.
So which is a risk with some of the others.
So it's much, among this family that we've talked about, all these drugs, this one's the least antibody the propensity to make antibodies against it is much, much less.
Yes.
So far we've had good experiences, haven't we?
We have, yes. Yeah. Yes, definitely with this drug, yes.
Okay. Kim, Mel, I've asked all the questions I want to ask. Is there anything else you want to say before we wrap up with Tofacitinib?
No.
No? Brilliant. That's a wrap. Thank you very much.
Thank you.